Recently, Families for Intractable Pain Relief provided input on several occasions to the task force. We recommended, or we commented that they fail to address what we've called the overlooked condition of constant severe intractable pain. These folks, many of them are the high-dose patients. We call them outliers. In any set of data, you're going to have outliers. Well, our family members are outliers in terms of symptoms and often their doses. Constant excruciating pain. We think that the federal government could serve our population very well by educating physicians, pharmacists, law enforcement, regulatory agencies at state levels particularly, that pain of this nature really does exist. My husband is a real human being, and the pain that I've described is real. It's debilitating and may lead to early death if not adequately treated. My last bullet doesn't really pertain too much to the other content of the slide, but it occurred to me in looking through that people have also in the past seemed to doubt him, often physicians or other healthcare providers. Well, you don't look like you feel that bad. We had a nurse tell him in a hospital, you don't look like you're hurting that bad, so I'm not going to give you the medication. People with severe pain can smile, and they do smile. Best practices to us would include recommending that for patients like my husband who have been on a successful regimen for over 8 years, the best practice is to leave them alone and let them continue. Please avoid mandating changes to successful protocols. Changes are very destabilizing and difficult, not only to the patient, but to the entire family. I would say that one can best measure success by 3 outcome metrics: pain control, functional capability, quality of life, as reported by the patient with confirmation by a family member. Frankly, from my point of view as a family member, MME is irrelevant. Outlier patients often have limited ability to metabolize medications, and it's not what the number is, it's how my husband's doing. High-dose therapy can be a legitimate practice for patients for whom all else has failed. It's been practiced for many years by some practitioners as a last resort. It's not new, it's helped many. There are criteria that have been written about in terms of what patients might be eligible. They've been published in Practical Pain Management, and I would think it might be helpful to take a look at those. In the current environment, we fear that doctors will not come back to pain practice until the federal government provides some sort of protection in the form of criteria. So use what's out there as a starting point. Too much delay is really a significant problem because people are dying by suicide and by impacts of undertreated pain, people who have lost their care. We still have care, we just don't have access to the best medication, and we're fighting that. We're talking frequently with the Commonwealth of Virginia government to try to get them to backtrack on some policies they have adopted that caused the harm. I think we face an ever-growing crisis with too few doctors, too few pharmacies, and too many Americans suffering needlessly. What can cause a requirement for unusually high doses? Here's a few things: cytochrome P450 abnormalities. Some people have malabsorption due to disorders of the digestive system or extensive gut surgeries. And it's now believed there's damage to pain control receptors due to tissue degeneration, particularly if you're talking about people with genetic connective tissue disorders and arachnoiditis, adhesive arachnoiditis, etc., which now are my husband's recent and new diagnoses. Pros and cons for extended release. I'm a big fan of extended release because they get my husband a consistent level of relief where he's not up and down all day long. Many myths about intractable pain patients. Who are these people? They are in any number of walks of life. All of the people up here, these occupations represent friends of mine, people that I know. And what's at stake? Really the right to life, liberty, and the pursuit of happiness, because you can't live your life when you're chained to the couch. What can FDA do? Thank you for holding this meeting. Please continue to talk to patients, help change the public narrative, educate to combat the stigma. We would very much support a special REMS or a training program so that people can sign up to help these folks. My husband, in his own words, wrote to FDA that he now feels like there's some social experiment has failed and he's no longer important. It's not important to treat him. Does he deserve to be thrown out like yesterday's garbage? I would say remember that smiling face, and certainly he deserves compassionate care like anyone else. Thank you very much.
Thank you.